Good morning, everyone. Welcome to the third day of the June 23rd to 25th regularly scheduled ACIP meeting. We have two items on our agenda today, but before we begin on that, I'm going to take roll for the ACIP members. Today, it's not necessary to state your affiliation or your conflicts, as there's no vote. So let me begin, I'm going to skip Dr. Alt. We know he's not going to be here right now in the morning. Ms. Bata.
I am here. Good morning.
Good morning. Dr. Bernstein. I will come back to Dr. Bernstein. Dr. Chen.
Wilbur Chen here.
Good morning. Dr. Daly.
Matt Daly here.
Good morning. Dr. Fry.
Morning.
Good morning. Fry here.
Good morning. Dr. Cotton. Dr. Cotton? I will come back to Dr. Cotton. Dr. Lee.
Grace Lee here.
Good morning. Dr. Long.
Sarah Long here.
Good morning. Ms. McNally.
Good morning, Veronica McNally here.
Good morning. Dr. Paling.
Good morning. It's Kathy Paling, and I'm present. Thank you.
Thank you. Good morning. Dr. Sanchez.
Good morning, Pablo Sanchez, present.
Good morning. Dr. Talbot.
Good morning. Rick Talbot's present.
Good morning. We have a lot of morning people here. Dr. Bernstein, are you here?
Good morning. Sorry I'm late. Yes, I am here.
No need for apologies. Glad you're here. Good morning. Dr. Cotton.
Good morning, Camille Cotton. I am at Massachusetts General Hospital, where I am the Clinical Director of Transplant and Immunocompromised Host Infectious Disease and Associate Professor at Harvard Medical School. I have no conflict.
Thank you and good morning. Very good. So all present except for Dr. Alt, who will join us later. So today we have two topics, Zoster vaccines and pneumococcal vaccines. I'm going to turn it over to Dr. Cohen to see if she has any words for us before we begin.
I have nothing else to add. We do not have any votes today, and we will not have a public comment period. So hopefully we will get everybody out at the scheduled time today. We can go ahead and introduce Dr. Lee.
Very good. So we'll start with the Zoster vaccine, and I will introduce Dr. Lee to please give the introduction. And I'm sure everybody knows that Dr. Lee is the incoming chair of the ACIP. Take it away, Dr. Lee.
Thank you, Dr. Romero. I am delighted, but I am very happy you are still chair for as long as you are. So this morning I'm here to introduce the Zoster vaccine session. If you go to the next slide. I'd like to start by recognizing the 2021 herpes Zoster work group, including my fellow ACIP members, Lynn Bata and Camille Cotton, our invited consultants, many of whom have significant expertise in caring for immunocompromised hosts, our ex officio members and liaison representatives. And I especially wanted to thank Dr. Tara Anderson, who has been doing an outstanding job leading our work group and ensuring that we continue to move forward to address these complex and extremely important questions. Next slide. So as a reminder of the timeline for the RSV vaccine and where we are today, RSV was licensed for use in October 2017. And ACIP recommended RSV for use in immunocompetent adults 50 and older. As implementation was underway in the US for immunocompetent adults, clinical trials were ongoing for use of RSV among those who are immunocompromised, given the known higher burden of disease in this high-risk population. In August of 2020, the EMA approved an expanded indication for RSV in adults 18 and older at increased risk of Zoster. And the company then submitted a supplemental biologics licensing application to the FDA to support RSV use in immunocompromised adults 18 and older in the US. Earlier this year at the February ACIP meeting, the policy question and evidence to recommendations framework was introduced for this particular vaccine in question. Next slide. And the policy question was, should vaccination with RZV be recommended for immunocompromised adults 19 years of age and older? The overall population is immunocompromised adults 19 and older. And in order to help support decision-making, we split this adult population into those 19 to 49 and those 50 and older, since there already is an age-based recommendation for recombinant Zoster vaccine for those 50 and older based on risk. The intervention is 2 doses of RZV given at least 4 weeks apart, and the comparison is no vaccine. The outcomes we discussed that were deemed critical for this analysis are the prevention of Zoster under the benefits column and serious adverse events under the harms column. And additional outcomes deemed important include prevention of herpetic neuralgia and prevention of Zoster-related hospitalizations under the benefits, and immune-mediated disease, grade 3 reactogenicity, graft versus host disease for stem cell transplant recipients, and graft rejection for solid organ transplant recipients under harms. Next slide. Since the February 2021 meeting, the Zoster work group has met 6 times, where we reviewed a significant amount of data on GSK's studies on the use of RZV in immunocompromised populations, as well as independent economic analyses or assessments regarding use of RZV in immunocompromised populations. Next slide. So the goal for today is to review the primary data for 2 of the ETR domains, first on the public health problem, and second, what we know about benefits and risks. And our agenda will include specifically a review on the burden of Zoster in immunocompromised adults by Dr. Tara Anderson, and an overview of GSK's clinical program on the use of RZV in immunocompromised populations by Ms. Robin Wittmeyer, followed by discussion of the committee. Next slide. And with that, I'd like to thank my colleagues again on the Zoster work group who continue to contribute their time and expertise in order to support decision-making in this high-risk population. And I'll turn it over to Dr. Tara Anderson. Thank you.
Dr. Anderson, please. Burden of herpes zoster in immunocompromised hosts.
Okay, great. Thank you, Dr. Romero. I will now address the burden of herpes zoster in immunocompromised adults. Okay, regarding current ACIP recommendations for Zoster vaccination, the ACIP recommended recombinant Zoster vaccine, or RZV or Shingrix, in October 2017 for use in immunocompetent adults aged 50 years and older. ACIP recommends use of RZV in persons taking low-dose immunosuppressive therapy, for example, less than 20 milligrams per day of prednisone, or those using inhaled or topical steroids, and for persons anticipating immunosuppression or who have recovered from an immunocompromising illness. ACIP did not include immunocompromised persons and those on moderate to high doses of immunosuppressive therapy in this recommendation. Importantly, these patients were not included in clinical trials that led to FDA regulatory approval of RZV. As you will hear in the next presentation during today's session, several clinical trials of RZV in immunocompromised populations have since been conducted. The risk of herpes zoster, severe disease, and complications is generally higher in immunocompromised populations, and for some, zoster can be life-threatening. As we will discuss, though, immunocompromised populations are very heterogeneous, both within and across groups. Zostavax, a live attenuated zoster vaccine, was contraindicated for persons with immunocompromising conditions. So recombinant zoster vaccine can potentially address the need for prevention of zoster and its complications in immunocompromised populations. Millions of persons in the United States are immunocompromised. In the 2013 National Health Interview Survey, approximately 7 million adults self-reported immune suppression. There are a total of approximately 3 million among stem cell transplant recipients, patients with hematologic malignancies, renal or solid organ transplant recipients, and patients with solid tumor malignancies, and people living with HIV. In addition to these groups, there are approximately 22 million with more than 80 diverse autoimmune and/or inflammatory conditions, such as systemic lupus erythematosus, rheumatoid arthritis, and inflammatory bowel disease. These patients often have underlying immune defects, but generally are not considered frankly immunocompromised unless they are on immunosuppressing treatments. Importantly, an increasing proportion of immunocompromised patients are likely to be treated with immunosuppressive medications. And again, of note, Zostavax was contraindicated for most immunocompromised patients. As noted during the February 2021 ACIP meeting, the work group is considering the following immunocompromised populations: hematopoietic stem cell transplant recipients, patients with hematologic malignancies, renal or other solid organ transplant recipients, patients with solid tumor malignancies, people living with HIV, and immunocompromised populations at increased risk of zoster not covered in groups 1 through 5. So that is patients with primary immunodeficiencies, patients with autoimmune conditions, and patients taking immunosuppressive medications. As previously noted, immunocompromised populations are very heterogeneous, especially considering the range of potential immunocompromising conditions included here and the use of immunosuppressive medications. In addition, some patients may be immunosuppressed for months, while in the case of some transplant and autoimmune conditions, immunosuppressive treatment may be lifelong. So today we will further discuss the first domain in the Evidence to Recommendations, or ETR, framework introduced during the February 2021 ACIP meeting, the public health problem, or zoster and its complications, and the public health importance, given the risk of zoster and its complications in immunocompromised adults. These photos show some of the clinical presentations of herpes zoster. As you can see, zoster can be painful and debilitating in healthy people, and in immunocompromised people, it is more common, more severe, and more likely to result in long-term effects. In some cases, zoster can result in blindness, devastating postherpetic neuralgia, or death. Postherpetic neuralgia is the most common complication of zoster, and this patient's experience highlights how debilitating it can be. As previously noted, this is even more likely to develop among immunocompromised patients. So herpes zoster is common in the general population. There were approximately 1 million cases per year in the United States during the pre-herpes zoster vaccine era. As you can see in this figure, zoster rates increase with age, with incidence rates ranging from about 2 to 9 per 1,000 persons. As previously noted, the immunocompromised population at risk for zoster is substantial, but estimating burden of disease requires a clear understanding of zoster incidence and severity in these groups. A systematic literature review regarding the risk of zoster in groups 1 through 5 was recently conducted. It was noted that the median zoster incidence estimates for these immunocompromised groups exceeded those reported for immunocompetent adults 50 years and older, and this is depicted in the figure on the right. The incidence rate of zoster ranged between 9 and 95 per 1,000 person years. As you can see, there was variation in study estimates for the cumulative incidence and the incidence of zoster within each group and between groups. Ultimately, risk within each condition varies due to the underlying disease and therapies received. For stem cell transplant recipients, zoster risk varies depending on the type of transplant received and complications such as graft versus host disease, both of which may affect the type and timing of prophylaxis received. For solid organ transplant recipients, zoster risk correlates with the intensity of immunosuppression, with the highest risk for heart and lung transplant recipients, followed by kidney and liver. Solid organ transplant recipients are on lifelong immunosuppressants, while stem cell transplant recipients may be able to discontinue their use, so risk may vary over time among populations. In the systematic review, it was also noted that zoster complications and severe disease were increased in immunocompromised populations. However, the data were insufficient to assess risk by group. Regarding available data, for postherpetic neuralgia, or PHN, approximately 6 to 10% of immunocompromised patients experience PHN. Oh, it's closer, sure. Okay, excuse me. Versus about 4% overall in administrative claims databases. And between 6 and 45% experience PHN across immunocompromising conditions and studies. For disseminated zoster, approximately 3% of immunocompromised patients experience disseminated zoster, but it is exceedingly uncommon in healthy persons. And between 10 and 17% mortality has been associated with disseminated zoster among renal transplant recipients. Finally, 8% of stem cell transplant recipients with zoster are hospitalized versus less than about 1% of overall Medicare beneficiaries with zoster. As you can see, better evidence of the incidence of zoster complications and severity in immunocompromised populations are needed to inform economic and zoster vaccine policy analyses. Another important consideration for these patients is that antiviral prophylaxis is recommended post-transplant. However, there is no universal standard prophylactic regimen for transplant recipients, and antiviral drug duration and dosage vary. Studies of patients post-stem cell transplant, with follow-up for more than 2 years, revealed that zoster incidence increases once prophylaxis is discontinued. Importantly, compliance is often poor, leading to zoster during incomplete prophylaxis. The long duration of prophylaxis is often a factor in compliance. According to ACIP General Best Practice Guidelines for Altered Immunocompetence, most inactivated vaccines should be initiated 6 months after stem cell transplant. As previously noted, there is great heterogeneity between and across the immunocompromised populations under consideration. This is an even more significant reality for Group 6, which includes patients with primary immunodeficiencies, patients with autoimmune conditions, and patients taking immunosuppressive medications. Regarding the risk of zoster in Group 6, included here is a figure and brief summary of findings from a study evaluating the risk of zoster in autoimmune and inflammatory diseases. In this study, the authors determined that there is an approximately 2 to 4-fold higher risk of zoster in patients with autoimmune and inflammatory conditions than in healthy individuals. It was noted that the risks varied across conditions and by age groups, and age-standardized zoster incidence rates varied, with the highest rates in patients with systemic lupus erythematosus, or SLE, inflammatory bowel disease, or IBD, and rheumatoid arthritis, or RA. Another recent study identified similar results with an approximately 1.5-fold higher risk of zoster for unvaccinated Medicare beneficiaries with AI conditions versus those who were not immunocompromised. As previously noted, for some autoimmune conditions such as SLE, IBD, and RA, the risk of zoster is about 2 to 4-fold higher. And importantly, age-specific incidence rates among 21 to 50-year-olds can be comparable to or substantially higher than corresponding rates in healthy adults greater than 60 years of age. The impact of immunosuppressive treatments is another consideration for these patients. The standard of care is for patients to be on 1 or more immunocompromising drugs, the duration of which could be for months, years, or lifelong. In addition, it's not possible to define high-risk subgroups based on anticipated drugs, since treatments, including disease-modifying antirheumatic drugs, glucocorticoids, and biologics, are very different from condition to condition and even over time for individual patients, based on their response, tolerability, and other factors. As noted during the February 2021 ACIP meeting, the work group has extensively reviewed these and other findings and concluded that zoster and its complications in immunocompromised adults is of public health importance. Important points from work group discussions include that immunocompromised populations are very heterogeneous, both across and within groups, and among individuals over time. The risk of zoster and its complications is generally higher in immunocompromised populations, although there is variability across and within groups. It is not feasible to define every possible immunocompromising condition and medication combination, and that it's important to consider broad recommendations and appropriate guidance for immunocompromised populations. Regarding next steps, the work group will continue to review available evidence regarding the use of RZV in immunocompromised adults to address the remaining ETR domains listed here during future ACIP meetings. Thank you for your time and attention, and I'll now turn things back over to Dr. Romero.
Thank you very much. We are going to take questions now. Okay, so this is open for discussion at this time. Let me just pull up my list to see if anyone has any questions. Does anyone from the voting members have any questions or need of comment? I am not seeing any. From our liaisons, any questions or comments? Dr. Goldman, please go forward.
Thank you, sir. Just a quick question. In looking at the immunocompromised adults, did they look at those who had received the varicella vaccine as children for the 19 to 50-year-olds? Was that considered in any of the studies, and the risk of zoster after that?
We don't believe that that was something that is routinely captured in these studies, but it's definitely something that the work group has been discussing in terms of the importance of that for these younger age groups within the populations under consideration.
Are there any other questions or comments? I'm not seeing any. Dr. Anderson, thank you very much for that very nice presentation.
Thank you, Dr. Romero.
And we'll move on to the next presentation, which is the use of recombinant zoster vaccine in immunocompromised populations by Dr. Wittmeyer.
Thank you very much. Good morning. And perhaps we can also address that question following this presentation as well. This is Robin Wittmeyer speaking, Global Medical Affairs at GSK. I do want to first thank the ACIP for your time today. It is my pleasure to provide an overview of the clinical development program for the recombinant zoster vaccine for immunocompromised adults. And we'd also like to take the opportunity to thank the principal investigators and study teams for their work on the 6 clinical studies that will be described today. And we do want to acknowledge and thank the patients who volunteered to participate. It is their participation that has allowed us to evaluate the recombinant zoster vaccine in several populations who are at high risk for disease and allows us to help inform the recommendations of ACIP. There is certainly a great unmet need with respect to shingles prevention in the broad and diverse group of patients who are considered immunocompromised, and this includes those who are compromised due to their underlying disease itself, and those who are immunosuppressed due to the necessary therapies to treat their underlying conditions. Next slide, please. The graph is summarizing the incidence rates reported in the literature for adults with a variety of conditions. And while incidence rates vary, they are typically several-fold higher than that of otherwise healthy populations of the same age, with patients undergoing stem cell transplants representing the most severely immunocompromised populations, and among those at greatest risk for herpes zoster disease and severe complications. The recombinant zoster vaccine was developed as a non-live vaccine in order to potentially offer protection for these patients who are contraindicated for live vaccines. Next slide, please. GSK first sought to address the unmet need for adults 50 years of age and older, since this represented the largest group of patients at risk for disease, and the majority of cases occur in adults over 50 due to immunosenescence. The approach for addressing the unmet need in immunocompromised populations took into consideration the very heterogeneous nature of this population of patients and the understanding that it's not feasible to define and study every possible condition or medication or combinations thereof. We considered an approach to address the key characteristics of these patients, which were most likely to influence vaccine efficacy and safety. And these characteristics were age, underlying disease, the type and duration of immune suppressive therapy, and the timing of vaccination in relation to that therapy. Through our clinical program, we evaluated the vaccine to understand the benefit-risk profile in the context of these factors and the interrelated effects of combinations of these factors for any given population and patient. And now I'll provide a high-level summary of each of the populations we included in the clinical development program. Next slide, please. Starting from the bottom of this slide, our early phase studies enrolled patients living with HIV and patients who had recently undergone an autologous hematopoietic stem cell transplant. Today, we'll focus our presentation on the phase 3 program, which included vaccine efficacy, immunogenicity, and safety evaluated in patients following an autologous HSCT, the most severely immunocompromised population included in the clinical program. We also evaluated immunogenicity and safety in patients with hematologic malignancies, solid tumors receiving chemotherapy, and patients who recently received a renal transplant. The next slide will provide an overview of each of the phase 3 studies and how they allowed us to evaluate the vaccine in the context of the patient's age, their underlying disease, immune suppressive medications received, and the timing of immunization with respect to that treatment. Next slide, please. This is an overview summary of the 4 late-stage studies as part of the clinical program and how they can demonstrate the potential impact of these factors which can influence safety, immunogenicity, and efficacy of the vaccine. Each study focused on a different specific category of underlying disease with several different specific underlying conditions included in each study. All studies enrolled patients 18 years of age and older, and we also analyzed the data by age group, 18 to 49 and 50 plus. With respect to age distribution, the study populations were representative of the incidence and prevalence of the underlying conditions, with approximately 25 to 30% of subjects, depending on the study, in the younger 18 to 49 age group. Within each study, the patients were receiving the standard of care at their treatment center, which included a variety of classes of immune suppressive medications. And finally, the timing of vaccination was variable by study. All autologous HSCT patients were vaccinated 50 to 70 days post-transplant. Those with hematologic malignancies were immunized either during their chemotherapy cycles or shortly following their chemotherapy course. For patients with solid tumors, they received their first dose of study vaccine either before the start of the chemotherapy cycle, so first dose pre-chemo, or they received their first dose on the same day as the start of the chemotherapy cycle, first dose on chemo. And the second dose was administered at the start of a subsequent chemotherapy cycle. In renal transplant patients who are chronically immunosuppressed, they could receive their vaccination 4 to 18 months after their transplant. This represents a very heterogeneous population by age, underlying disease, by treatment, and as well as timing of vaccination. And we have shared detailed data from each of these studies with the working group, including the exploratory sub-analysis on specific underlying diseases, age groups, and timing of immunization where possible. Due to the time limitations today, we'll focus the presentation on the main study endpoints, which included the full study populations as defined within each protocol. Next slide, please. The design of each of the phase 3 studies was consistent. 2 doses of study vaccine were administered with the second dose 1 to 2 months following the first, and with all participants followed for at least 1 year following immunization. Blood samples were taken to evaluate both humoral and cell-mediated immune responses, and safety endpoints were evaluated in the standard time frame across all studies and consistent with the previous pivotal studies completed in immunocompetent older adults. Next slide, please. We will start with a review of the safety data. What I'll share in the next few slides is the pooled reactogenicity data across all 6 studies in the clinical program. And the next slide shows the solicited local symptoms, which we're providing also by age 18 to 49 and 50 plus. Next slide, please. Here are the local symptoms. The first set of bars represents the proportion of subjects reporting any local solicited symptom, then the individual symptoms of pain, redness, and swelling. Here, the lighter bars is the 18 to 49 group, 18 to 49. Darker bars are 50 plus, and the gray bars are placebo. The red bars embedded within are the grade 3 solicited symptoms. We do see more frequent solicited symptoms reported in the vaccine group compared to the placebo group, and a trend for more subjects reporting local symptoms in the younger age group. The local solicited symptoms are largely mild to moderate in intensity, with a duration of a median of 3 days. The median duration of grade 3 symptoms was 1 to 2 days. The next slide shows the general symptoms. Next one, please. We notice a relatively high proportion of subjects in the placebo group reporting these general solicited symptoms, which are common symptoms for these patients due to their underlying disease and the treatments they're receiving. We see the trend for more younger subjects reporting these symptoms compared to the 50-plus group. The solicited general symptoms are mostly mild to moderate intensity. Median duration was 1 to 3 days, depending on the symptom, and the median duration for grade 3 symptoms was 1 to 2 days. On the next few slides, I'll share the other safety results in terms of overall adverse events, serious adverse events, potential immunity diseases, and the safety endpoints for relapses, disease progressions, or allograft rejection for the appropriate studies. For these safety endpoints, we will show the data for the individual studies rather than the pooled analyses. Next slide, please. Starting with the unsolicited, non-serious adverse events, shown here by age group as well. These were collected in all studies for 30 days following each dose. There were no imbalances for adverse events between the vaccine and placebo groups, and similar proportions of subjects reporting AEs for the 18 to 49 and 50-plus age group. On the next slide, we'll show the serious adverse events. Next one, please. Here are the serious adverse events shown here collected for 1 year following vaccination. There were no imbalances for serious adverse events between the vaccine and placebo groups, and similar proportions of subjects reporting SAEs for the 18 to 49 and 50-plus age group. In some studies, there were more SAEs reported in the older age group compared to the younger, which is expected due to the age and underlying conditions. Importantly, no imbalances between vaccine and placebo groups in any study, and no imbalances when specifically looking at serious adverse events that were considered related by the investigator or any fatal serious adverse events. Next slide, please. The number of potential immune diseases reported was very small, so I am showing the pooled data across all 6 studies on this slide, and we've magnified the scale so we can see the data more clearly. There were no imbalances between vaccine and placebo groups, no imbalances when looking specifically 30 days post-vaccination or within the year since vaccination, and no imbalances for any potential immunity diseases which are considered related by the principal investigator. On the next slide, we'll summarize the underlying disease-related events that were collected for the phase 3 studies. Next one, please. We evaluated disease-related events, which were disease relapse or disease progression in patients with autologous HSCT or those with hematologic malignancies, and there were no imbalances between the vaccine and placebo groups in these studies. In patients who were immunized following renal transplant, 4 patients in the vaccine group had a biopsy-confirmed rejection. 7 patients in the placebo group had a biopsy-confirmed rejection, and there was no apparent impact of vaccination on allograft function overall during the study as measured by the serum creatinine levels, and graft survival during the study was 100%. Overall, as described, there were no safety concerns identified in the clinical development program for immunocompromised patients, which is of primary importance. So with that, we now turn to potential benefits, and I'll describe the vaccine efficacy and immunogenicity results. We evaluated efficacy in 2 study populations. Vaccine efficacy was the primary endpoint in the most severely immunocompromised population, those who recently received an autologous HSCT. We also evaluated efficacy post hoc in the study of patients with hematologic malignancies. And we were able to do this post hoc analysis since the study included the same robust herpes zoster case ascertainment as was used in the pivotal vaccine efficacy studies. So I'll show the efficacy results on the next slide. First, the pivotal vaccine efficacy trial in patients with autologous HSCT. They received their vaccination starting 50 to 70 days post-transplant with the aim to protect them during the time post-transplant when they are most at risk for herpes zoster. And the vaccine efficacy was 68.2% over a median follow-up of 21 months post-vaccination. We also evaluated vaccine efficacy by age, 18 to 49 and 50 plus, with consistent efficacy results demonstrated in both age groups. As a secondary endpoint, we also evaluated vaccine efficacy against postherpetic neuralgia with an efficacy of 89.3%. In the post-hoc efficacy analysis in patients with hematologic malignancies, they were vaccinated either during or shortly following completion of their chemotherapy course, and vaccine efficacy was 87.2% over a median follow-up of 11 months following vaccination. Next slide, please. We'll now review the immunogenicity results. Next one, please. As a reminder, the design of the phase 3 trials was very similar, with blood draws, blood samples at consistent time points, baseline, 1 month post-dose 2 representing the peak immune response, and 12 months post-dose 2 to evaluate the persistence in the year since vaccination. What we'll share is the humoral and CMI results for all phase 3 studies across all these time points. And on the next slide, we'll start with the humoral results for each study, and also as a reference to data from the pivotal phase 3 Zoe 50 study in immunocompetent older adults. Next slide, please. Here are the humoral responses as anti-GE-GMCs. We have pre-vaccination, the first bar, post-dose 2 as the darkest bar, and then 12 months post-dose 2 in the third bar of the set. This is on a log scale with the precise values noted above each bar. In this diverse population of various underlying diseases and treatments and timing of vaccination, we did observe a humoral response in all populations that persisted above baseline 12 months post-dose 2. On the next slide, we will share the CMI results. Next one, please. Here are the CMI responses as the median frequency of GE-specific CD4 positive T cells. And again, in all populations we have studied to date, we observe a robust immune response with persistence above baseline for 12 months following immunization. Next slide, please. Summarize, we reviewed our approach to address the unmet need and evaluate the recombinant Zoster vaccine in a diverse group of immunocompromised patients who are at increased risk for disease, either due to their condition or the treatments they're receiving. The reactogenicity profile was as expected based on our clinical experience and the nature of the underlying conditions. Adverse events, serious adverse events, potential immune-mediated diseases, relapses, disease progressions, or allograft rejections were balanced between the vaccine and placebo groups. Efficacy was demonstrated in two populations, 68.2% in the autologous HSCT recipients, and post-hoc 87.2% in those with hematologic malignancies. The vaccine was immunogenic, even considering the impact of age, underlying disease, immunosuppressive treatments, and immunization either before, during, or after immunosuppressive therapy. And based on the safety profile and immunogenicity and efficacy data, we believe the benefit risk is favorable for these patients who are at high risk for herpes zoster disease, and therefore have submitted an application for an expanded indication in the U.S. to include immunocompromised or immunosuppressed adults 18 years of age and older. Next slide, please. There is work ongoing, and we have shared with the working group more details on the ongoing clinical plan we are pursuing. And the funnel on this slide is meant to represent that we continue to build on the phase 3 program just described to continue to generate evidence to support decision-making for the many high-risk patients with a variety of conditions, comorbidities, and the vast array and evolving array of use of many different therapies. I'll conclude here, and I again want to thank the ACIP for your time today.
Thank you very much for that presentation. We are now open for discussion. Dr. Paling, please.
Dr. Wittmeyer, thank you very much for this presentation on a very important topic and a very clear presentation. There's two questions that I have for you. One is, could you please clarify what was the placebo that was used in these studies? And the second was, could you clarify the retention of the study population in both the RZV and the placebo groups? Thank you.
Yes, thank you for the question, and I'll ask my colleague, Dr. Vink, to confirm, but I believe in all studies, the placebo was normal saline. Peter, can you confirm that was similar for all studies?
So the placebo was normal saline combined with a sucrose. So the presentation was milky in color as our adjuvanted vaccine is. But we did not use the adjuvant alone as the placebo, but it was sucrose and saline.
Thank you. And the second part of the question was the retention in the study. So in terms of the vaccinated cohort, we had over 90% of participants who received the second dose for compliance for the second dose, and inclusion into the cohort for efficacy analysis was very high. In terms of the overall completion rate, I don't have those numbers off the top, but I'll ask again if Dr. Vink recalls what the completion rate was for the study.
Completion rates varied by the study, primarily by the underlying condition. So certainly subjects who had progression of their cancer or relapse of their cancer would come out of the study for other therapies. But generally that was balanced between treatment and placebo groups.
Are there any other questions from the Dr. Kimberlin? Please go for it.
David Kimberlin, AAP Red Book. Can you comment on local and systemic adverse reactions, not compared with placebo, but rather what was seen in the immunocompetent populations that led to the initial licensure?
Thank you for that question. So if we look at the Zoe 50 study, for example, when we look at local solicited symptoms, they are quite similar between the IC and the older adult populations. As noted, we do see more general solicited symptoms occurring in the IC population. So they are reported at a higher rate in the IC groups compared to the older adults, which may be expected because of the underlying conditions and immune suppressive medications. But generally, consistent what we expect based on what we know in terms of the response to the vaccine. In terms of grade 3 symptoms specifically, as an example, about 22% of participants in the IC program had any grade 3 symptom, and it was around 17% for the older adult population.
Dr. Sanchez.
Thank you, Dr. Mero. That was a very enlightening presentation, and thank you. My question was related to the placebo, which has been answered, but I was just wondering, the data you presented was mostly after 2 doses, right? So how does that compare after the first dose only? And how much of a boost do you get with the second dose, if you looked at that separately? And my last question is, are you looking at a younger population, less than 18 years of age?
Thank you for the question. So as I mentioned, the compliance in the studies was very high, so we aren't able to do robust evaluations in terms of one dose. To provide some information, though, in the solid tumor study, as I mentioned, the first dose could be administered prior to the start of cytotoxic chemotherapy. The second dose for all subjects was administered on the same day or within 1 day of receiving cytotoxic chemotherapy. And so therefore we did, as expected, see an impact in terms of the response of that second dose when it's administered with therapy versus giving the time for the immune system to generate a response before their treatment. So we anticipate that the response to second dose, response to either dose would be impacted based on the timing of vaccination. And in terms of studying younger populations, in this clinical program, we focused on the adult population. But I would like to ask Dr. Vink or maybe Dr. Armstrong around the pediatric studies that were required in Europe.
So this is Dr. Vink again. We are doing pediatric studies in Europe. We're in a initial study at this time with pediatric renal transplant patients. This is a step-down study. We just received our clearance from the IDMC to step down from our older 11 to 18-year-olds to our younger population. This is not with the full-strength Shingrix. This is with a reduced adjuvant formulation, since we do see higher reactogenicity with full-strength AS01B adjuvant. Studies are ongoing, and I can't say more about them at this point in the analysis in the studies.
Thank you.
Thank you for those answers. Are there any other questions from the voting members or the liaisons? Not seeing any. Thank you very much for these presentations. We're going to take a 10-minute unscheduled break at this moment. So we'll come back in 10 minutes. Thank you very much.